Welcome to AETCM, the Emergency Medicine Channel. Today I will be presenting a case of a 78-year-old male, known case of interstitial lung disease, who came to our ear with complaints of acute onset worsening of breathlessness associated with dry cough and high-grade fever since 2 days. On initial 10-second assessment, patient was conscious, oriented, obeying commands. In primary survey, airway was patent, there was no pooling of secretions or gurgling sounds. Coming to breathing, there was bilateral breathing movements were equal. He was not able to complete full sentences. There was bilateral coarse crepitations in all zones of lung, more over the lower zones. Bilateral wheeze was also present. Saturation was 75% on room air. Respiratory rate of 38 per minute. At this point, we started him on 7 liter O2 by mask. And
what mask you selected for this patient? Face mask.
Face mask.
So initially when you have a patient with hypoxia, you can start with the maximum percentage of oxygen that can deliver. So you can start with an NRBM. So NRBM, how much percentage FiO2 you will be able to deliver?
NRBM up to 100%.
From 60 to 100% FiO2 you will be able to deliver in an NRBM. So initially if the patient is having hypoxia, you start off with an NRBM, then you can slowly titrate and reduce. Based on the patient's requirement. If patient is attaining that saturation, you can slowly reduce. Okay. What is the most, so this patient is a known case of ILD. So what is the most common respiratory failure expected in an ILD patient?
Type 2 respiratory.
Type 1 more than type 2. The ILD means interstitial lung disease. The interstitium is the area which is outside the alveoli and between the pulmonary vessels. So that area will be affected initially, then progressively it will affect the alveoli and the pulmonary vasculature. And initially it will cause type 1 respiratory failure, and as it progresses because of chronic hypoxia, towards the last stage it will go to type 2. So initially we need to correct that with NRBM. Okay, so this one we'll start with NRBM. Okay.
And coming to then nebulization, duolin was given. Salbutamol plus ipratropium bromide. 3 cycles, 20 minutes apart was started. Coming to circulation, BP was 160 over 90 millimeters of mercury. Pulse rate of 114 per minute. All peripheral pulses were felt and equal. CRT was less than 2 seconds. At this point, 18 gauge IV cannula was inserted, and cardiac monitor was connected. Coming to disability, GCS was of E4, V5, M6. Pupils are equal and reacting to light, moving all 4 limbs. Exposure GRBS of 211, temperature of 101.4 degree Fahrenheit. We came reassessed again, and in breathing part, saturation only picked up to 83%. So we started, and respiratory rate was remaining around 34 per minute. So we started him on a non-invasive ventilation.
So this patient actually saturation only improved to 83%. So we ideally we could have initially converted to an NRBM, increased the oxygen, and then we could have seen. Then if still patient is not improving and if there is respiratory distress, we will start on NIV. Okay. So what all are the oxygen delivery devices which you know?
Initially we can start the patient on nasal prongs up to 4 liters of O2. Then from 4 to 10 we can start on face mask.
Face mask, okay.
After 10 to 15 we can start by NRBM.
Okay. So maximum only 4 liter you will be able to give through a nasal prongs. So how much percentage can be delivered maximum?
Maximum 1 liter is approximately 3 FiO2 increase. So baseline is 21 FiO2 on room air plus 3 into 4. So it will be around 33 around.
Almost 40% FiO2 will be delivered by a nasal prongs. Then
face mask.
Hudson's mask. Face mask is also known as Hudson's mask.
Face mask we can deliver up to 70.
40 till 60 to 70, 80 that range will be delivered. Okay.
And 60 to 900 we can deliver.
So in face mask, how much liter oxygen you can put from 5 to 10?
5 to 10.
Okay. And NRBM?
NRBM 10 to 15 liter, that is 60 to 100
percentage. Okay. What is the difference between a face mask and an NRBM?
NRBM will be
nasal prongs will be like two small tubings will be
tubings
given. Face mask and NRBM are two masks. So what is the difference?
And NRBM, there will be a reservoir bag also.
Other than that?
Also, side.
Closed. So thing is, face mask is having two openings. So along with the oxygen which we are supplying, the room air also will get entered inside. So it will be a mixture of room air along with the oxygen. So that's why we can give only up to 60 to 80% of FiO2. Whereas NRBM, it is not open. The mask is not open. It is having a valve. So whatever carbon dioxide we are exhaling out will be going out through the valve outside, and the room air won't be able to enter inside. That is one valve which is on the mask, and another valve is there that is coming from the reservoir. So whatever oxygen is there in the reservoir will enter inside the mask, but the carbon dioxide will not go back to the reservoir. So two valves are also there in an NRBM along with the reservoir. Okay. And if we don't have this, what other oxygen delivery device can be used before going to NIV?
High flow nasal cannon.
Yes, high flow nasal cannula can be, HFNC can be used. Okay, HFNC, we can set HFNC based on the FiO2 requirement. We can set an FiO2 and we can give through the HFNC, and make sure that we have the HFNC machine with us, and also this oxygen should be given along with the vaporizer also, otherwise the patient will have discomfort. Okay. So this patient, so ideally we would have tried an NRBM and then we would have converted into an NIV, because mostly the problem is type 1 respiratory failure. So if we correct the hypoxia, mostly the distress will come down. Okay, so what setting was kept for NIV?
Maybe BiPAP setting with 16:8.
Okay, and FiO2?
FiO2 of around 70%.
70% also. Okay. Then what happened was patient?
Yeah, then patient had saturation of 98%.
Okay.
Maintaining. Adjuncts of primary survey.
And also patient had a temperature also, right?
Yeah, temperature. So, we also gave injection PCM. Paracetamol 1 gram IV stat was given.
Okay. What was the ABG finding?
ABG, it showed pH of 7.28, PCO2 of 72, bicarb of 30.6, sodium 128, potassium 4.2.
What is impression?
It's showing a respiratory acidosis. Partially compensated.
So there is carbon dioxide PCO2 more than 60. Yes. So there is definitely a type 2 respiratory failure also. Now NIV can be, NIV anyway we started. So now there is a reason for NIV. Okay.
And point of ECG was taken, which showed P pulmonale in leads, in almost all leads it was present.
When will you tell there is P pulmonale?
P pulmonale if the height of P wave is more than 2.5.
2.5 millimeter. Okay. Okay. What other changes will you have? Will there be there?
In this patient also there was ST depression, T wave inversions in V2 to V4, and with the prominent R waves in V.
What was the heart rate in this patient?
Heart rate was 114.
114. Maybe tachycardia induced depressions. Okay.
Then prominent R wave is present in V1 to V3.
Okay, RVH features are also. Okay. What other features will you see in a patient with chronic hypoxia in ECG? There can be features of pulmonary artery hypertension. That is what is called as P pulmonale. Then if there is right ventricular hypertrophy, you can see that. What else can be seen?
RV strain pattern.
RV strain pattern.
More in the subtle anterior leads.
What is MAT?
Multifocal atrial tachycardia. It is a irregular narrow complex tachycardia, and that with at least 3 different P wave morphologies.
So that also can be present. That can be seen in ILD patients and also COPD patients. Okay.
A point of care CBC total count showed 22,000 and CRP of 210.
Okay. And what else should be asked for in this patient bedside? Chest X-ray?
Chest X-ray also.
Why chest X-ray? Why should we ask for a chest X-ray in this patient?
To look for pulmonary edema or any consolidations.
Anyway, this patient already is having interstitial lung disease, so there will be changes. In order to see any new onset effusion or any new onset of any consolidation change. That's why we are taking. And since this patient is having bilateral air entry and all, we are not suspecting a pneumothorax. But in this patient, since their alveoli are damaged, there is a tendency for a rupture and pneumothorax also. So X-ray should be done, and bedside ultrasound of the chest also should be done. Okay.
Coming to secondary survey. This is a 78-year-old male who is known case of interstitial lung disease, type 2 diabetes mellitus, and hypertension. He had history of breathlessness and dry cough since past 2 months. Over the last 2 days, he had acute worsening of breathlessness, which progressively increased from MMRC grade 2 to grade 4, with orthopnea and PND present, and it was relieved on sitting up. It was associated with increased frequency of dry cough, and he had high-grade fever with chills and dry cough since yesterday. There is no history of chest pain, profuse sweating, syncope, palpitations, drug defaulting, or any altered sensorium. He has had 4 such episodes in the last 1 year. He has no allergies to any medications. He is on furosemide 40 mg twice daily, clinidipine 5 mg, mucolite, human actrapid, and lantus. There is past history of exacerbation of ILD, 4 episodes in last 1 year. On examination, patient was conscious, oriented to time, place, and person, moderately built and nourished. Grade 2 clubbing was present. Bilateral pitting pedal edema was present.
Before going to that examination, you can tell the vitals again.
Vitals. Okay. Vitals was saturation of 97%, maintaining respiratory rate of 24 per minute, BP of
with 70% FiO2.
Yeah,
Right.
70% FiO2 with BP of 160/90, pulse rate of 114 per minute.
Okay.
And there's grade 2 clubbing was present, and bilateral pitting pedal edema was present. No pararictus or cyanosis or lymphadenopathy. Systemic examination, respiratory system, upper respiratory tract, nose, oral cavity, pharynx, larynx were normal. Coming to lower respiratory tract inspection, trachea was central, bilateral chest symmetrical, with movements, symmetrical movements are equal. Use of axillary muscles are present. No kyphoscoliosis or any sinuses, scars, or dilated veins. On palpation, trachea was confirmed to be central. No tenderness. Chest movements are bilaterally equal. No chest expansion of 1 centimeter. Vocal fremitus was reduced in all areas. Percussion, resonant note in all areas. Auscultation, there was scattered coarse crepitations heard in bilateral zones, bilateral upper, middle, and lower zones, and vocal resonance was reduced in all areas. Rest of the systems, CVS system, there was S1 S2 was present with no murmurs, and JVP was elevated around 6 cm above sternal angle.
Why is that?
Most probably due to the right ventricular hypertrophy, right ventricular
pulmonary artery hypertension causing back pressure. Okay. Along with that cardiovascular system examination, you might have heard a loud P2 in the pulmonary area because of the pulmonary artery hypertension.
CNS high mental functions are normal, no focal neurologic deficit. JIT soft, there is soft and non-tender. Impression is acute infective exacerbation of ILD, core pulmonale in heart failure.
Which heart failure?
Right heart failure.
Probably right heart failure.
X-ray review and
this patient with X-ray we won't be able to find which heart is failed.
No, like pulmonary edema is there.
Pulmonary edema features. So usually right heart failure secondary to a pulmonological cause, it will be mostly right heart failure. So anyway, this patient is having bilateral lower limb edema, features of this is raised JVP, these things are also there. Also in abdomen you could have checked for the tender hepatomegaly, that also might be there, suggestive of right heart failure. Okay. What was there in X-ray? Patient's X-ray?
X-ray, like bilateral infiltrates are present.
Okay.
No consolidation as such.
Okay. They are ILD patients are prone for effusions and mediastinal lymphadenopathies and all. Okay. That was not there.
Not there.
Okay. Then how did you treat the patient?
We started initially we did management for the breathing part. Once he was stable, we gave him nebulization. Duolin was given. And then counts was elevated, around 20,000 was there, with CRP elevated. We started him on injection piperacillin tazobactam 4.5 gram. Stat dose was given.
Why was that selected?
Because to get for gram positive and gram negative coverage and anti-pseudomonal.
Coverage. So ILD patients are they are having a damaged alveoli and lungs, so they are prone for pseudomonas infection also. That's why Piptas was started. Okay.
And injection paracetamol was given for the fever. And for the fluid overload, we had given injection furosemide. 40 mg IV stat was given.
So before already this patient is on furosemide tablets. What was the dose for already taking?
Already taking 40 milligrams twice daily.
Twice daily. So before giving furosemide, just cross check with the inferior vena cava. And what is the normal size of IVC? Normal size 1.5 centimeter. If it is dilated, IVC is dilated, and if there is no collapse of IVC during inspiration, that means it is dilated. In that case, we can give an injection. This patient's BP is anyway 160/100, so we can give furosemide injections. So since patient is taking 40 mg, so how much extra should you give? Double the dose. So you will have to give at least 80 mg of furosemide. Okay. Then was infusion started?
Lasix, after that injection Lasix 0.6 ml per hour infusion was started.
Okay.
And, then investigations all was and CBC, CRP, blood culture, sputum culture.
Usually ILD patients will be having dry cough. Because of this interstitial problem, cough will be dry. Very rarely only they will be able to bring out sputum in these patients. Okay. And along with that, if we are admitting into our ICU, we will have to titrate the patient's BiPAP requirement. Based on the ABG, we can titrate the BiPAP requirement. How will we titrate?
If there is improving PCO2, if retention is going away, then we can reduce by 2. Like if it is initially 6, we start on 16.8, we can make it 14.7, like that we can decrease 12.
You can reduce FiO2, but you can't reduce less than, if you are reducing the inspiratory pressure, you can reduce it maximum up to 15. Below that, if you go, that means enough pressure is not there, because normal inspiratory pressure is around 15. So you can reduce it up to 15, and PEEP don't reduce less than 5, because normal physiological PEEP is 5. So it shouldn't go below 5. So if you are able to titrate like that, then you can slowly taper off BiPAP. That means BiPAP usually is spaced and then stopped. So you can give 4 hours of BiPAP and you can give 1 hour of break. If patient is tolerating that, after 1 hour, just reassess and you can restart. So one day you can observe like that. Then next day onwards, you can titrate in a sense like you can give BiPAP for 2 hours, you can space for 2 hours, like that. Another third day, you can give 1 hour of BiPAP and you can give a 3 hour spacing. Like that, you can space and stop. Then what else is required? This patient is having right heart failure secondary to pulmonary artery hypertension. So any drugs to be started? I think phosphodiesterase inhibitors like sildenafil, these things should be started. And already if a patient is having ILD, for prevention of pulmonary artery hypertension, you will have to start this patient. This patient already developed a pulmonary artery hypertension. So for prevention and for treatment, these patients should be discharged with what? Tablet sildenafil along with, for prevention you can start oxygen. So ask these patients to take LTOT. That means at home, ask them to take oxygen based on the requirement of the patient. And LTOT can be started in the form of either nasal prongs can be used at home or Venturi mask. Venturi mask is a mask which can give FiO2 to the patient, like depending on the patient's demand, how much FiO2 is required based on that. Because if we are giving a nasal prongs and all, the bystanders who are there can increase the oxygen and give extra oxygen to the patient. So the extra oxygen can cause hyperoxia. Hyperoxia can cause free radical damages to the lungs. So in order to titrate and give sufficient amount of oxygen, we can give Venturi mask. That will give only fixed dose of FiO2 to the patient. Like we have 6 colors for Venturi mask. So we can either use a blue will give only 24% FiO2. Then there is white, which will give 28% of FiO2. Then there is orange color, which will give 31% FiO2. Then yellow is there, which will give 35% FiO2. Then there is red, which will give 40% FiO2, and there is green, which will give 60% FiO2. So if you are using a Venturi mask, depending on the patient's requirement, we can calculate the FiO2 required, and that color Venturi mask can be given to the patient and ask them to take LTOT at home. So minimum 10 to 16 hours that patient should get oxygen, so that the patient will not go into a pulmonary artery hypertension. Okay. And while follow-up, we can ask them to come back and do a pulmonary function test. Anyway, we'll be showing a restrictive pattern only. We can look for the exercise capacity of the patient by doing a 6-minute walk test and all. For 6 minutes, you ask the patient to walk, and we can assess how much distance the patient is able to cover with that 6 minutes, and we will chart it on each review, and we will be able to see whether the patient is improving or not. Okay. Anything else? Okay, thank you.